children that we diagnose with KD to have seen multiple care providers by the time they see us. The average is about 3 care providers that have seen your child before he or she is diagnosed with Kawasaki disease. And despite efforts over many years that have been done by Dr. Burns and myself to try to teach people how to diagnose Kawasaki disease, and we do that on a daily basis with our residents, our medical students, and we give talks and travel, we still find, unfortunately, that even in our own backyard, children are missed. So we've decided that the real big task that we have to do is to develop a diagnostic test so that we give our physicians in emergency rooms and urgent cares, pediatricians' offices, the tools in order to be able to diagnose your child properly and early so that we can intervene and prevent, of course, the heart disease. Am I in the right direction? There's this one too. I'll try this again. There we go. So this quote is a lovely quote that I've heard in Spanish. Dr. Burns has heard in India when she traveled there. And it's, the eyes do not see what the mind does not know. And so our job really and our task is to teach people what Kawasaki disease looks like. And if you don't know what you're looking for, you'll never diagnose it. And there are many clinicians, because this is a clinical diagnosis, that aren't looking for the clues about KD. So I'm going to show you how we're using different techniques to bypass that or to augment what physicians see so that they can diagnose Kawasaki disease. We all know why we're here, why we worry about Kawasaki disease. It's for preventing the aneurysms. And we know, gratefully, that early treatment reduces the risk of coronary artery abnormalities in Kawasaki disease, that big white arrow there. That's what we're trying to prevent. We also know that the diagnosis of KD is still being missed, that children present to us with peeling, that we have dermatologists that call us saying, you know, I think this child may have had KD. They came in with this peeling around the nail bed, and when I sat down and took the history, this child actually had a fever and a preceding illness that sounds like KD. So because of that, there's always a question of which child really has Kawasaki disease. Dr. Burns and I love showing this slide because you put this up not only for our parents, but you put this up, we just put this up at the American Heart Association meeting and the American College of Rheumatology. And a lot of physicians are very hard-pressed to figure out which of these kids actually has KD. And it's only this one here. So how do we figure that out? How do we not only pick up the kids that have it, not overtreat the ones that don't have it, and don't miss the ones that do? So it turns out that our emergency department sees many, many children with Kawasaki disease. We have nearly 100,000 visits in our ER every year, of which nearly 7 to 10% of those are actually for unspecified fever. So when someone says to me, what's the market for a diagnostic test for Kawasaki disease? Our response is actually quite simple, in that it's really going to be any child that comes in with a febrile illness that's prolonged. And it could be the fever rash kid, it could be the fever red eyes kid that is seen. So there is a really large market when you think of how many kids could have this test done. So that's actually from a standpoint of dealing with companies to market this and to put this out there. That's a great thing that we have. And we always tell them as well that the lawyers will take care of this as well, right? Because unfortunately children are missed, it becomes a legal issue, and so there's a reason from a legalese standpoint to also run this test if it becomes available. So how are we doing this? We are looking at this from multiple avenues. We're looking at biomarker test development. We actually have an iPhone app that is currently being evaluated with our collaborators up at Stanford, for which we have a patent. We're working on a urine test, and then I'll also talk to you about some cool stuff called natural language processing that's dealing with the electronic medical records that we have in our hospitals. So we think of this as a race, and we're thinking about, yes, horsies. We think about this as a race of, and it's a race of these different tests. It's also a race against time, frankly, as a clinician that cares for these patients. Because we want there to be something that's available quickly, and it may be that what we put out initially is not the best test, but we need to have something out there. And we need to be able to have all these things happening at once. So we actually have all of these different projects with our collaborators across the US and across the globe to figure out which was going to be the most effective test. So let me talk to you about the different approaches. Let's talk about biomarkers first. we say biomarkers, we mean proteins that are measurable, mostly in the blood. So this dates back now about 5 years ago, and I always like to show this because I think it's important to realize where this all stems from, and it really stems from the families here in the audience. So this is a family, it's entitled Boys Disease Drives Mothers Fundraising Efforts Towards Cure. And this family that we took care of held a KD Fund Day for us over 5 years ago, and they raised $25,000 to run this set of proteins. And this is where this all really got started, with looking at different biomarkers. Now what we realized from that work is that if you look at these curves, you would love these curves to go all the way up to what we call the y-axis, all the way on your left, and then all the way up across the top. And that way the entire box would be diagnosed with Kawasaki disease. What you see here, what we call receiver operating curves, the ROC. And so it means that 83% of the kids that had KD were able to be diagnosed by these tests, pretty much. So that's pretty good, but it's really not great enough. So this is where this all started, and we've taken off from there and with many different panels. So I want to talk to you about our collaborations with Dr. Michael Levine that Dr. Burns introduced a little bit ago at the Imperial College of London. And so he had a beautiful paper in New England Journal of Medicine last year looking at diagnosing of childhood tuberculosis. And what he's doing with these blood samples that we've been collecting from your children and from the rest of our patients, he's been looking at ways to diagnose Kawasaki disease using a very similar technique. So this is one thing that we currently have in the pipeline. Another approach that we've been taking is actually something called natural language processing. And this takes the advantage of what every physician pretty much now has to do, which is deal with the electronic medical record. So I spend my day when I'm seeing patients in front of a computer, when I'm not with the patients, putting data into the computer. The point of this is to be able to analyze what's there and really ask the question, when the ER doc sees your kid in the emergency room, can the computer pick up a child that should be considered for Kawasaki disease? Because I'm sure many of you had the experience where you went in and your kid may have just had fever, okay? But maybe you took your kid in when your kid had fever, rash, and red eyes. And then everything else started to manifest a few days later, and you think, well, shouldn't they have been thinking about KD a couple of days ago? So this actually helps with that process. This is how it does it. So this is a little story, a vignette taken from the medical record from one of our patients, actually. And it's a 2-year-old male seen in the emergency room yesterday for vomiting for the past 5 days. Okay, so 5 days gets tagged by the computer as fever. Presenting for fever, that also gets tagged as one of the signs that we see, things that we see in KD. Vomiting, decreased oral intake. The patient had a rash, so that gets tagged. Started 2 days ago just on the cheeks and the back. Today the patient has rash. Progressed down the neck on the chest pain. Then they had fever, and then you can see the timing. And then if you skip to the last part, patient has diarrhea, no blood. Patient's eyes became bloodshot yesterday. That gets tagged as conjunctival injection, or the eye redness. And lips were cracked and dry. All right? So when you read this, any parent who has a kid with KD would say, child has Kawasaki disease. But it may not be that this all happens at the same time with the same provider. It may be that he saw you 2 days ago, isn't seeing you today, didn't see the progression of things. So if the computer can read this and can ping the physician and say, did you think about Kawasaki disease? Then we've actually made a step forward, right? And then that brings up the question that should this child be assessed further by maybe some blood work looking for KD. So that's what's called natural language processing, where the computer is processing the natural language, the typed in stuff, or spoken stuff that we put in as clinicians. So this then tags the clinical signs and symptoms. It creates a scoring system that we've developed. So if you have at least 3 KD signs plus fever, then it says, you should really be thinking about Kawasaki disease, and it alerts the provider to suspect KD. Okay, so now this physician's sitting there in the ER, they get this ping, and they go, I gotta think about KD. What do I do next? Well, that's where the next step comes in. This is where we're now developing a diagnostic test using a cell phone app. And we've done this in collaboration with Bruce Ling's group up at Stanford. And really the point here is to take all the things that we commonly see in our patients, their clinical picture, as well as the things that we measure from the blood work, and ask, what's the likelihood that this child has Kawasaki disease? Okay? This is kind of imitating what Dr. Burns and I do on a daily basis, taking all the patients that we've seen, all that information we know about Kawasaki disease, and figuring out in our own minds how likely does this kid has KD. We're now asking the computer to do that for us. And here's an example of what this would look like, where what you're seeing there is that you have the demographics with the age and gender of the child, all the clinical signs of KD, as well as the blood work. And then the physician or someone helping that physician out would put in this information, and the computer gives you a probability of how likely this patient has Kawasaki disease. So now we're pinging the physician and saying, think about KD, and then we're giving them an app in order to be able to understand how likely it is this kid has Kawasaki disease, and should they be contacting someone to either admit this patient or to work this patient up further. And this gives you an example of what we did initially. Now, this was published in the Journal of Pediatrics a couple of years ago, and it was the first iteration of what we've done. And what you can see here in green are what we call febrile controls. Those are kids that come in looking like they have KD, but ultimately are diagnosed to have something else. Or the red, which are the children that actually have Kawasaki disease. And so if you're to the left here, you definitely don't have KD. If you're to the right here, you definitely have Kawasaki disease. And you can see that we're able to pick up a lot of the kids, but we're still missing. We're missing all these kids in the middle that have an overlap. So again, this was good but not great enough, so it made us keep working, and this is what it's led to. So now we have this whole algorithm set up with the kids with the group up at Stanford, where what I just showed you, that group in the middle, is this indeterminate group. We're not quite sure what they have. And then we said, why is this not working? What's going on with this algorithm? Where is it failing? And it turns out it's failing because we're mixing all the kids together. So what we decided to do was we decided to create an algorithm that works for kids with only one clinical criteria for KD. Those with 2 criteria, 3 and greater than either 4 or 5 criteria. So now there's all these different things going on in the computer that all hinge upon how many signs of Kawasaki disease does this child have. And then you go on to have, of course there may be some kids you still can't diagnose, but that group becomes smaller. So now we have this whole algorithm that takes you through the thinking process of, could this kid have Kawasaki disease? How many criteria does he have? And there's a couple of different ways to figure that out. So we're making some very significant progress. It's actually been submitted for publication, and we're very excited about being able to push this algorithm forward and ultimately, frankly, into the clinic would be it. So what are we doing to validate that? Because we've done this with our information, with our database. So what happens when you test this? And so we're currently testing this with a group at CHOP, with a group at Children's Hospital Colorado, Nationwide Children's in Columbus, Ohio, and Boston Children's Hospital. And what we're going to be asking with their data sets is, where does this work and where does this fall apart in order to make it better? This is a very circular, iterative process that we've been doing now, frankly, for the last 5 years. We'll continue to do, where we're trying to get something that is good enough where we feel like we're missing a lot less kids. So that's where that is. So let's move on and talk about urine. Right, so unlike blood, which is kind of hard to get in our kids, as you guys all know, urine sometimes may be a little bit easier to get. And wouldn't it be super cool if we had just a regular dipstick for Kawasaki disease? So that's what we're trying to work on. And here we have some data that shows some of the work that we're doing to look at urine differences between kids that have other diseases that are not Kawasaki disease and KD. And you can see clearly here that the light-up pattern is different. So we're working very closely, again, with the group up at Stanford in order to validate these tests and to see if we can really move the needle forward in terms of developing a diagnostic test for Kawasaki disease. So at the end of the day, what we're looking for is somebody who's going to win the Triple Crown, okay? But I will tell you, though, that if we have a winner in this race that isn't the clear winner, meaning that we're not going to be able to pick up everybody, but it's a really good test, we're going to work on getting that out there. So a lot of people have asked me, why aren't you developing some fancy tests with brand new biomarkers for Kawasaki disease? And that is also certainly in the works of what we're doing. But frankly, in order to be able to get something like that to market, it takes a lot of time and a lot of investment. If I can get an iPhone app on physicians' phones tomorrow, and it works 80 or 90% of the time, that for me right now would be good enough and better than what we have, right? So we will continue to do this work and continue to move this mission forward with the understanding that eventually it may be a combination of different things. And we really have to see how these things work in real time. And my husband's an emergency room physician, so I know clearly how ER, I know very well and hear all the time about how ER works and the pressures of medicine outside of the research lab. And we want to have something that's practical, realistic for clinicians to do to be able to diagnose kids earlier. going to finish just by thanking everyone that has been so helpful with this work, all of our collaborators through Stanford, Imperial College of London, most certainly our Katie Foundation and our families. We are, this work really, you can see it hinges upon the samples you guys have been willing to provide from your children, and of course the funding agencies that make this work feasible. So with that, thank you.
So a lot of questions came up during the break about what really causes Kawasaki disease and what are we working on. I showed you this slide earlier about the increasing incidence of disease in Japan. We think that's because of increasing exposure. And so we're going to talk a little bit more about some of the theories. Everything that I'm going to tell you about today is a hypothesis. That means that these are ideas that we have that are being tested. So none of this is fact. This is all data that we're analyzing that we will be subjecting to rigorous scientific methods to really try to understand the answers. So we think that there is an environmental trigger, and I got up in front of a large audience of pediatric infectious disease specialists and told them that I really suspect that Kawasaki disease is not an infectious disease. And we're going to talk a little bit more about what category of disease it is. Some of the questions in the break were, is it an autoimmune disease? And no, we do not think that it belongs in that category of disease either. We think that there's an environmental trigger. It could be part of a bug or a bug piece, but not the actual living organism. It could be something else from the environment that these children breathe in, and because of their genetic susceptibility, they manifest the reaction and the changes in their body that we recognize as Kawasaki disease. So a number of different microbial agents, fungi, yeast, living bacteria, viruses have been looked at, and none of these so far have panned out as a plausible cause for Kawasaki disease. However, we know that it's very seasonal, and there's no question that during the fall, early fall months, we have a real lull in the action, and then it begins to build, and it continues to build in our community here until March, which is our really peak month. So Dr. Tremblay and I are very, very busy in March when we've got lots of patients. And then there's another peak in the summer after a brief respite in the spring. So it's very seasonal. And when we wanted to investigate why this should be so seasonal, we hooked up with the team at Scripps Institution of Oceanography, Dan Kahan and his group, as well as the Japanese epidemiology workforce, because Japan has the highest number of patients, and we thought we could better study it in that environment. So we analyzed a large time series of Japanese patients, and we looked at the seasonality over a period of 19 years, and we basically created these maps where you see red, there are a very high number of patients in that prefecture, so that specific location in Japan, in that month. So month number 1 is January, and then this is like a calendar, and you go through to month 12 in December. And you can see that where it's red, all of the country is having higher than the average number of cases. And where it's blue, in the months of the early fall, October and November in Japan, there's a real lull in the action. So again, in Japan, using a very large data set and being able to apply very robust statistical analysis, we could show that there's absolute seasonality to this disease, and that there are essentially 2 peaks. One in the winter month of January in Japan, a different month here in our country, and then another peak during the middle of the summer. So there has to be a reason for this. This is not a random distribution of patients. So the clustering is statistically significant, and we're searching for the answer. So we expanded the research team and added on a group in Spain, led by Chevy Rodo at the Climate Institute there. And we wanted to know if there was some regional scale climate pattern that triggered the clusters of Kawasaki disease patients. And Chevy Roto and his team analyzed a lot of different variables, and they came up with an association with tropospheric winds. What you're looking at here in the top panel is the time series of Kawasaki disease patients with the big epidemic spike in 1982 and 1986. And so when you're a climate scientist, what you do is you study what we call anomalies. So every year there's winter, spring, fall, and every year there are some Kawasaki patients and fewer Kawasaki patients. But if you really want to get to the heart of the matter, you look at the anomalies, the years where something very different happened. And so he studied the climate variables around the time of the epidemics in 1982, 1986. And what you see in the lower panels here is the pattern of wind coming from a region in China. So these red dots are indicating very high numbers of patients in Japan corresponding to the 1982 epidemic, and this is 1986 over here. And then these lines are the directionality of tropospheric winds. So these are winds traveling more where jet airplanes travel, not wind blowing in your face standing on the ground. And what you see is this direction coming from, this is Korea and this is China here, coming from this region. And when the epidemic subsided, then the winds reversed and blew in the direction that is the more normal seasonal direction, which was coming from the Pacific Ocean across Japan in this direction, shown by these little arrows here. And this was a highly statistically significant difference from the usual pattern, and so this got their attention. Again, the winds that we're talking about that they're measuring, this is all from satellite data, and it's the winds that blow between 5,000 and 10,000 kilometers above the surface of the Earth. And then they did an analysis that included both San Diego and Hawaii. So what you're looking at here are, in the upper panel, actual numbers of Kawasaki disease patients in Japan in the red, a mathematical derivative of the wind direction in blue, and then a derivative of our Kawasaki patients, because we have smaller numbers for San Diego and Hawaii. But you can see that there's a real joining of these two patterns. So the red lines and the blue lines are coinciding, suggesting, and again statistically significant result, that there's a relationship of some sort between the direction of the wind and the number of KD patients. So we got together with a group of people interested in this problem and came up with the idea that the tropospheric winds must be carrying something that when inhaled by genetically susceptible children causes KD, and that this wind coming from Asia was carrying something that was going to affect children both in Japan and on the western coast of the US, but that there would be other source regions in other parts of the world. But the Asia, Japan, Southern California, and West Coast axis was where we wanted to focus our study because of the large numbers of patients and our very robust data sets from these areas. So last year, the tracing of the wind, where was this wind coming from, what could it be carrying, was published by the climate team. And I want to go through with you just briefly what that analysis was. Basically, the story with wind is that when wind is going slowly, it both picks up things from the ground as well as rains down or deposits things that it's been carrying from elsewhere. So I have to confess that I missed the climate class in medical school. So this has all been on-the-job training for me, and I'm not a climate scientist. But I can tell you that the people we collaborate with are really smart, and they really are good climate scientists. So I think the data are very trustworthy. So the analysis that they did was essentially to create a box of wind that they were then going to trace, so back tracing of the wind. And they took this box of wind from the satellite data that they created over Japan at a time when there was a very high number of cases happening. And they asked the computer, where was this wind 3 hours before? And where was it 3 hours before? And using these amazing satellite databases, they can actually reconstruct this entire story for each of the winter epidemics that happened with great regularity in Japan. So they did this for many, many years, and they did this for this particular season when there were a large number of cases. And they were at the same time looking at the location of the wind, but also they were looking at the speed of the wind. Because remember, the wind is only exchanging things when it's moving slowly. So the question they were asking is, where is the last place, as we backtrace these boxes of wind, where is the last place where it was slow, and before that, it was going faster? And when they did that, they created this little map where the mustard-colored region is where the wind was traveling slowly. So here's Japan, here's Korea, and here's China. And when they backtrace the wind, so wind moves in a circle. I didn't know that, but I know that. And when the wind was back over this part of Siberia here, here's Mongolia and China, the wind was going very fast. But it slowed down as it reached this landmass here, which in the dark red are areas of very heavy agricultural pursuit. And this is new and a change after World War II. So when Mao took over in China, there was a great reorganization of Chinese agriculture. And this area was very, very heavily planted with wheat, with sunflower. A lot of grain crops were grown there. So that's the origin of the wind that seems to be carrying something that is at least statistically associated with increased numbers of Kawasaki disease patients in Japan. And specifically, it's this region of China, Heilongjiang province and Jilin, I'm sorry for my bad Chinese pronunciation, are the regions that were highlighted as a potential source region for whatever is being carried in these winds, which might be carrying the KD agent. So if we think about long-range transport of infectious diseases or even particles that cause disease without it being a living thing, if we look at a dust particle that would be of the size that you could actually inhale into your lungs, if we looked at it under the electron microscope, it would look something like this. So we think of dust particles as little round balls, but actually they're full of nooks and crannies and places where proteins or different molecules or even organisms could hide and be safe from the degrading effects of the UV light that is very powerful at that high altitude. So things could travel buried in these dust particles across large distances. And there's an example of this that we know from studies of the Saharan dust storms. And these dust storms, it turns out, that originate over the Sahara and the Sahel regions of Saharan Africa can be carried in these plumes. And you see the plumes here as these green and red clouds of dust. And as they travel across the Atlantic Ocean, when they hit the warm waters of the Caribbean, these wind currents slow down. And you all remember what happens when wind slows down. It drops its payload as well as picking things up from the ground. And it turns out that it's dropping spores of this fungus, Aspergillus sadowii, onto the ocean surface where it then sporulates, and it's infecting the fan coral. And so for those of you who snorkel in the Caribbean, the fan coral is dying off, and this is one of the reasons. This is a pathogen or a germ that causes disease in the fan coral. So obviously we're not talking about human disease here, but here's an example of how something could be traveling on a wind current and cause a problem at a distant site. So we enlisted the help of Hiroshi Tanimoto, who's the head of the National Institute of Environmental Sciences in Tsukuba, Japan, and he provided aircraft that were flown during a time of lots of KD activity on the ground, and we were collecting these samples. These were then handled very carefully so as not to contaminate them. They went to Ian Lipkin's laboratory at Columbia University, where they have great expertise in handling nucleic acid, that's the DNA and the RNA, in a special way not to contaminate them. And what was blowing in the wind that we found that had not been reported before was fragments of yeast. And so we wondered about the possibility that this could be related to triggering Kawasaki disease. Many of you have seen this slide or heard about this association of carpet shampooing and the exposure to freshly shampooed carpets with the onset of Kawasaki disease. So this is the National Enquirer, that well-known medical journal that you see when you check out at the supermarket. And the real article was published in Lancet. I was part of the team at that time at the University of Colorado that made this association. It was an investigation by the Centers for Disease Control. Unfortunately, this is a very distorted recording of our scientific paper. But it is possible that my life will actually come full circle, and that in the 1980s, when we made this observation about carpet cleaning, maybe the carpets actually do contain something that rained out onto them that gets aerosolized, and some children, when exposed to that, could actually develop the disease. So we now have land-based samplers on the top of a building in Kanazawa where we're collecting these samples. This is what we call a KD wallpaper, where we're analyzing the San Diego cases. This is a calendar, a piece of the calendar from 2011 to 2012. Everywhere where you see a yellow box that says 1, there was the onset of 1 case here in San Diego. Where you see 2 or 3, there were multiple cases. And we're analyzing the wind patterns, looking at the deserts where there were no KD cases, and then the clusters where there were multiple KD cases. And then we're working with the oceanographers at Scripps Institution of Oceanography to look at the climate patterns both preceding and during the onset of those dry spells, as well as the bursts of KD activity, and looking at these pressure patterns. So I'm going to leave you with the thought that now with the Macklin funding, we hope to be able to meet that challenge grant and be able to bring some more scientists on board to actually push this work further, to do a detailed analysis of the regional story and be able to understand what actually causes the disease in these children. So, thank you.
Pharmacology, actually, and in particular, I love that when we give a child a particular medication, we have a rationale for doing it, that we know what dose to give, that we know what the effects are going to be, and that we have something measurable, some kind of change that's happening. And I have to say that in pediatrics, just to give you a sense of perspective, 75% of the medications that we as pediatricians give to children do not meet the FDA labeling recommendations. So there is a huge push nationwide, worldwide going on to get better data in kids and to really be able to know exactly what a drug does and what the right dose is. And I have to say that I'm very proud of the work that we've done in Kawasaki disease that I'm going to talk to you guys about today, because we're really trying to understand biologically, physiologically what happens in Kawasaki disease, and then rationally choose targets and medications that get to those targets to really be able to block what's going on in Kawasaki disease. I'm going to go ahead and share with you the work that we've been doing. So we're all here in the room familiar with intravenous immunoglobulin and aspirin. And this has been the mainstay therapy for Kawasaki disease since the early 80s, when the large study that Dr. Burns actually just, if you don't know, was the one that enrolled the first patient in the IVIG study that was done, that now creates the standard of care for Kawasaki disease. And I think for many years we were very happy with this particular combination. We still are. It's what my 2 kids in the hospital today received over the last couple of days. But it's not all that should be out there, and it's not good enough for everyone. So when I joined the team now nearly 10 years ago, I was tasked by Dr. Burns to come up with something better. We had just come out of, we were in the midst of seeing a huge rate of children that were resistant to IVIG. We weren't quite sure why, and it was time to do something about that and to come up with better therapies. So that's where this first work comes from. So we had to sit down and think. And in doing so, we realized from the work that we've done, and again, remember that this is actually work derived from the blood samples that everyone generously donated, we were able to figure out that things like this protein called tumor necrosis factor alpha, a molecule that's made by the body that promotes inflammation, that this was very elevated in Kawasaki disease. And that this is kind of like throwing gasoline on the fire. So I described, as many of you may have known if you were my patients in the hospital, that I do describe Kawasaki disease as a fire. And that in many cases, just like bringing out just one fire truck and bringing out IVIG works. But in about 15% of our families, that's not enough. And in ones with the coronary artery damage, it's certainly not enough. So now we know that this is a molecule that gets made by the body that is high in KD, so what do we do about it? Well, it turns out that there's a drug on the market called infliximab that's marketed and FDA labeled for arthritis in adults and in children, and that decreases inflammation by inhibiting TNF-alpha. And the way that it works is if you think of these oval shapes of TNF-alpha, this antibody here that's made, it's part human, part mouse, that's made in the lab, goes and attaches to it so the TNF-alpha cannot engage on its receptor and set off these cells, like it's doing here. It can't set off these cells to then pass on inflammation and create inflammation. So it's blocking the inflammatory process from happening. So with that information, we decided, well, you know what, we should really try this in Kawasaki disease. And if you think about it, it's an interesting, additional therapy. So we thought, how should we really put this to use? What's the right group in which to do it? And so what we decided to do was to conduct a clinical trial where we were going to figure out if infliximab plus IVIG was the right initial treatment of Kawasaki disease. So should everybody that has KD receive IVIG plus infliximab? This was supported by the FDA. We're proud that we were the first FDA orphan disease grant awarded to UCSD to support a trial, a treatment trial, and with this in collaboration with Nationwide Children's. It was a 4-year study. Nearly 200 kids were involved. Many of you entrusted your own children to us to be enrolled in the study. And the goal was to decrease the rate of resistance to initial treatment of KD and prevent aneurysm. And that's what we were really trying to do, was to see if we could reduce IVIG resistance. So this was published actually last year, and it got some decent amount of press and got picked up, and it's nice to be able to know that we've been able to contribute to the work in Kawasaki to really hopefully be able to change how children are treated with this disease. So let me walk you through the data and the results. So our primary outcome was to try to reduce IVIG resistance, which we defined as fever 36 hours to a week after entering the first IVIG infusion. So that's why we're keeping your kids in the hospital for just an extra day to watch for fever to look for this resistance. Well, it turns out that there was no difference between the groups. Here's placebo. So here are the kids that got just IVIG, and here are the kids that got IVIG plus infliximab. And you can see that 11% in each group were IVIG resistant. So if you look at the data and you say, this study didn't work. Well, it turns out that there was some really interesting data besides this that did, and that's why it actually landed in the Lancet and got some press. And those data are the days of fever, okay? So we had 1 day less of fever. Now 1 day may not seem like a lot, but we all know how much it costs, and we all know what the pain is of being in the hospital for an extra day, all the things that can happen. So it did reduce fever, and in addition to that, it actually also reduced inflammation of the body overall that we could measure in the blood. In addition to that, we also have these changes in what we call Z-score. So Z-score is how we look at the coronary artery information, okay? And it allows us to compare what the coronary arteries look like over time. Okay, so, the measurements of the coronary arteries are standardized by the height and weight by the body surface area. And what we saw was a change in the Z-score from baseline, so when you come in with KD, of the left coronary artery over time. And you'll see that here. So blue is placebo, it's this top line, and red is infliximab. Okay, so everybody starts out here, but then over time, the kids that got infliximab had a more rapid decrease in the size of one of the coronary arteries. And so because of reduction of days of fever, less inflammation, at least some signal with at least the left coronary artery, we've now realized that although we didn't actually show that it improved resistance to IVIG, there's certainly a place for infliximab. The question is, what is that place? And what we realized was, and before I get to, I'll just mention this quickly, because this is very important. This was a huge study in the perspective of Kawasaki disease and really being able to show this is a safe drug. Infliximab is actually used over a long period of time, and in that situation, because it can suppress the immune system, there can be fungal infections that can happen, there can be tuberculosis that can happen in some patients over prolonged use if they're using it with other medications like steroids. But here we found that there was no difference in the adverse events between the kids getting placebo and the kids getting infliximab, and it was tolerated both in infants and in older children. So this drug is actually approved in the FDA for kids that are older, but we were using this for little babies because we felt really strongly that, that it needed to be done and we need to know the data. So we had 11 infants less than a year of age who received infliximab and didn't have any issues. So what is the role of infliximab in KD? In primary treatment, we know that it was safe. We know that that we had signs of biologic and clinical effect, but that we didn't reduce treatment resistance. And at Rady Children's, we now give infliximab to children with KD and coronary artery dilation or aneurysms on the first echo. I just gave it yesterday to a kid, right? So we got his initial echocardiogram, a dilated coronary artery, and I said to the family, this is what I would recommend, is that we go on and we give him the dose of infliximab to see. It gives him a couple of days ago, we got a repeat echo, and whether it was infliximab, whether it was time, and it was going to happen, his coronary artery looked better on the repeat echo gratefully. So this is something that has now become our part of our MO here, frankly, to give infliximab to kids with bad heart disease. And we're also thinking that it could be used in rescue therapy for IVIG resistance. Another possibility is to give a second dose of IVIG. I won't get into all the details with that, but there's actually some data now coming out that a second dose of IVIG in certain kids with certain blood types can actually cause the red blood, there can be a reaction, and red blood cells can lyse, and you can get anemia. And so because of that, there's been a lot of movement to use infliximab as a rescue therapy, and I'm very proud to say that we've been leading that effort, and that the data of its safety comes from our group. So then move on from infliximab, I'm going to talk about what, of course, the purposes of what we do. So that study with infliximab was really geared towards reducing IVIG resistance. But frankly, what we all work towards is reducing the coronary artery damage that happens. And the current way that clinicians deal with children with Kawasaki disease is that we follow echocardiograms for progression of coronary artery abnormalities. But there is no treatment to stop the progression of aneurysm. So you get an echo and it looks bad, and you go, God, that doesn't look so good. Well, let me get an echo in a couple of days. Okay, now it looks worse. All right, so now you're considering whether you just put this kid on some other medication as a blood thinner in order for that child to not have a clot. But we really don't have anything in our armamentarium other than the data I showed you on infliximab to know what we need to give a child once they have coronary artery damage. And so what we've decided to do now with the current two trials that we have ongoing here with our partner sites is that we're going to try to evaluate whether these drugs work for stopping coronary artery aneurysms, possibly reversing them, even preventing them. How does it deal with the coronary arteries? So how can we do an even better job of treating KD kids that have coronary artery damage? So I'm going to talk to you about our statin trial. A lot of people say statins. Wait a minute. Cholesterol is not part of Kawasaki disease. Well, that's not really why statins are in probably most of your medicine cabinets, or at least maybe in the grandparents' medicine cabinet. It's because of these effects here. Statins, so they weren't intended to do this, but it turns out that they are anti-inflammatory, they're antioxidant, and they prevent vessel damage and promote vessel healing. Which sounds good for the 70-year-old that had a heart attack. Well, this would also be great in the child that has Kawasaki disease that has coronary artery damage. But I want to make it very clear that the injury of the vessel that happens in Kawasaki disease is completely different than adult congenital atherosclerosis. We're not talking even about the same disease, the same kind of injury, the same look under the microscope pathologically. But if these are the effects of these drugs, maybe we can use those for our Kawasaki patient, even though the actual thing that's happening is a different disease. So we are doing what's called repurposing of a familiar drug. This is actually easier than trying to find a new novel target and create a brand new drug. Not that those options aren't being explored, but if you can take something off of the shelf and test it in KD kits, show that it works, and then use it, then I don't have to worry about partnering so much with drug companies and getting somebody to make something for a disease that, although it affects us all here dear to our hearts, it doesn't have a huge market, frankly. So our job has been really to look for drugs that are out there. And so I'll show you what the design is of our trial. A child gets admitted to radiation with Kawasaki disease. They're either 2 and above and they have bad heart disease, so they're eligible, or they have neural coronary, or they happen to be less than 2 years old. And that's set by the FDA. I'm happy to talk to you about why that is. But the line in the sand for us is 2 years and above for this trial. We get informed consent. We have what's called a dose escalation. So we start at a low dose, and then we go slowly increasing the dose in groups as we go along of the drug. And then we look for drug safety, how is it tolerated, measure drug levels, and then figure out whether or not it is anti-inflammatory and antioxidant. So we're very grateful that this was actually funded after the 4th attempt by the National Institutes of Health last year, and that we currently have a wonderful grant by the NIH to support this work. So currently we're enrolling at both Rady Children's Hospital and Children's Hospital Colorado. We have 17 of our 30 patients enrolled thus far. And we're well on our way to being able to evaluate the use of statins in Kawasaki disease and have that be potentially a way that we treat our kids with AIDS. We are currently at the 4th dose level, so we've enrolled kids at all these other 3 dose levels, and now we're at the highest dose level, and we'll just have to continue to see how we do and how this changes how we treat all of our kids. So I'm going to move on from statins to a drug called anakinra, right? And so anakinra is, we currently have a trial on anakinra as well. And I want to just take a moment and pause and tell you that we're not just kind of picking these drugs willy-nilly, that there is some very strong data from the research that we've done to show that just like with TNF-alpha being high using infliximab as our target for anakinra, I just want to stress that we have some very strong data from our work that shows that this group of proteins, the IL-1 alpha, IL-1 beta family, which is also an inflammatory protein, is very highly elevated in kids with acute Kawasaki disease. So when we got those data from the work that we've been doing, looking at RNA and protein, we said, wait, if this is so high, then we need to figure out if we can block this. And it turns out that there is a drug on the market called anakinra that does just that. That's why we're testing that. And this group, this family of inflammatory proteins actually then sets off all these signals that then increase things like TNF-alpha, which we talked about with infliximab. It then actually sets off all these inflammatory cells called Th17. It also causes smooth muscle cells to turn into these bad actors, these myofibroblasts, that replace the good cells in heart muscle with cells that don't function as well. And so our goal with the IL-1 alpha, IL-1 beta inhibitors with anakinra is to block this process. And that's where this comes in. What we want to create are cells, these tolerogenic dendritic cells that are good actors to be able to block what happens with myofibroblast formation and to really ask the question of what happens with cells like T regulatory cells that we know are critical in KD that stop inflammation, and can we block Th17? So we're learning a lot about the immunology in collaboration with Dr. Alessandra Franco. We're proud to be able to do this work with Boston Children's Hospital at our second site to be able to understand not only the immunology but also the way in which aneurysms form in our patients and how we can block them. So I'm going to lean for a moment on some mouse data. I know your children are not mice, but I will show you here that we have significant inflammation that happens in the vessel wall in a KD mouse model. That this is work from Moshe Ardini found up at Cedars-Sinai. And if you actually take a mouse and you remove its ability to have the IL-1 system go up and be inflammatory, you get a normal looking vessel. Okay? So by blocking this process, this IL-1, and he's shown this actually is also by blocking it with anakinra, which I believe has shown that there's actually some very good data to help prevent vascular damage, to prevent the coronary arteries from being damaged. So the current trial, much like the STACR trial, if you come into Rachel Hospital with Kawasaki disease, if you're greater than 8 months old, and that's another thing that's set by the FDA, but we now are a little bit younger, and you have some coronary artery damage, you may be eligible for the study. Similar process in assigning you to a dose, and we assess drug safety, drug levels, and anti-inflammatory effects. In collaboration with Boston Children's Hospital, we have actually enrolled 2 of our 30 patients. This is actually brand new off the runway with this study, so we're happy to be able to have these children enrolled thus far. So I just want to finish by saying that it really does take a village, and I'm very grateful to our patients and families. As you may all remember, if you've actually been to any one of our studies, we had just met you in the emergency room. It's probably very late at night, and you've been up for about 5 days with your child who's been ill. We just told you your child has a disease that you've never heard about. It sounds like a motorcycle. And now we're asking you to entrust your child to us to give them a drug, okay, that has some data in children, but not a lot, and hasn't really been used much in Kawasaki disease. I can't tell you how grateful I am every time a family says, you know what, this sounds something that you want to do, that we can do with our kid. Here's my child, and put them in our trust to be able to do that. So we're very, very grateful to all of you for being able to allow us to learn and to figure out. I will tell you honestly and truthfully that, especially coming from the AHA meetings, the American College of Rheumatology, from all the work that we do, we are being watched like hawks by the world, trying to figure out. Everyone wants something better for Kawasaki. Everybody's waiting for UC San Diego Media Research Center to figure out what that is. And we have people in line, Taiwan's in line, we have people in line from around the globe that want to do these studies. So we're just grateful for having you be part of our work. And I'm just going to leave you with one last thing before we start and be able to ask extra questions. I'm going to ask, I know Dr. Griffin probably already blogs in the hospital, I'm going to ask you all to go on social media tonight and to think about it over the holiday season as you think about everybody that has everything and what to give that person that has everything. Think about letting people know about Kawasaki disease and empowering families to really understand what this is. Until I have a diagnostic test in your local emergency room, there are going to be kids that are still going to be missed. And I really would hope that you can help us spread the word about what KD is, encourage people to participate, to have fundraising events to be part of our big fundraising mission, and to keep KD ever present, as it is a reality for all of you, and it is for us on a daily basis. So I thank you for your attention. We're here to answer your questions, and invite you to write your cards and we'll go to that. Thank you so much.